Good evening, everyone. This is Terry Ishmael from Shriners Hospital of Children in Philadelphia, and welcome to another episode of Scoliosis Dialogue, the official podcast of the Scoliosis Research Society. This evening, I'm excited to have Dr. Jesse Shen from the University of Montreal with me. Welcome, Dr. Shen. And tonight, we'll be discussing transition spinal care from pediatrics to adulthood. Welcome. So, Dr. Shen, why don't you tell us a little bit about yourself? Where did you grow up? How did you become interested in medicine? And how did you ultimately, choose to do what you do?
So first and foremost, thank you, Terry, for having me on the podcast. I'm really happy to be here. I'm born and raised in Montreal. I did basically all my schooling here in Montreal. I got into medicine initially because I wanted to have a purpose in my life. And then science was something that always was a driving factor. So I wanted to have a societal contribution while also have a scientific one. So that's how I got into medicine in the first place. And then that's actually one of the gateways that I ended up being, in a long-term relationship with one of my mentors right now, who's Stéphane Parra. From a pediatric spine surgeon who used to do a little bit of adults too. And that's how I got into contact with him, because I got into research in spine surgery, specifically in scoliosis and spondylolisthesis initially. Started off as a summer research student that became a master's student, look into AIS and 3D descriptors for AIS. And then I became an orthopedic surgery resident, got exposed to more spine surgery, and then started a PhD during my residency on congenital scoliosis and lung function in a basic science model. That was actually funded partially by an SRS grant that we applied for when I was a PhD student. So lo and behold, I got exposed a lot into spine surgery that got me interested in. And, there's an opportunity that came out to do adult spine surgery when we were looking for jobs afterwards. And then got interested in doing some adult spine surgery and ended up doing a fellowship with Raj Sethi in Seattle. So, I ended up getting trained from studying little kids with congenital deformities all the way to the older adults with adult degenerative scoliosis. So it gave me a good perspective, on the entire spectrum of disease. And so when I got back to the university, it felt just natural that, to keep my interest in the pediatric side, I'd be the connection between the two worlds. So now I'm a full-time adult spine surgeon at the University of Montreal Health Center, do a bunch of different type of surgeries. I don't just do scoliosis. We do tumor surgery, infection surgery, degenerative diseases as well. And I'm, like I tell my patients, I'm like the other side of the coin, I'm the adult side to Stefan. And since we've had that great connection, I know the team very well at St. Justin. Well, we ended up becoming clinical partners in a certain sense too, So now I'm the contact person for a lot of these young children who become young adults who are asking themselves, what do I do after I graduate from the pediatric center where I had awesome care, multidisciplinary care. So that's sort of the 2 minutes of my last 14 years of training and getting back into practice.
Yeah, that's wonderful. So why don't you tell us a little bit about, how this transition pathway works?
So it's it's actually a complex thing, when we talk about transitional care, it's been described in other complex pathologies, for example, like spina bifida or congenital heart disease. It's been described that it's not just about, hey, Dr. Shen, I have this patient, 50-degree scoliosis that I operated on. Can you follow them in 5 years? It's also preparing this young adult to be independent with their care and being knowledgeable of what was going on all these years, because mom and dad were calling the shots for a long period of time, So it's about also preparing them and providing a structure in which they could get access to continued care in my opinion, throughout a lifetime. We have to prepare them. The scoliosis is not curable. It's something that does become a chronic pathology. So transitional care is more of a holistic type of view of things. And in terms of current practice, the way we are doing it right now is that we have a dedicated clinical coordinator that's been working at St. Justin, the pediatric hospital, for a long time, that knows me very well because I worked as a resident and a research student there. And then I'm basically the point of contact for now at our adult hospital. And everything sort of gets funneled there in terms of a follow-up once patients get towards the age of 18. And even some of them, when we're looking at them becoming skeletally mature, 16, 17-year-old, we start looking at getting them seen at the adult side. It sounds very rudimentary, but actually organizationally becomes a little bit complicated at first because it's two different hospitals, two different physical locations with two different administrations. And we are a public insurer, so we have uniform insurance. So if it's complicated, even for us, I can only imagine in other sort of practice settings.
Yeah, that's amazing. I mean, I think that's unfortunately one of the things, or one of the programs, that we don't have enough of in spine surgery, or the pediatric to adult care. Like you said, it's very well developed in congenital heart disease and other pathology, but not so much in spine. So, I mean, what about other pathologies? Let's say, the 18-year-old with cerebral palsy who has, a progressive curve and the family didn't want surgery, et cetera. Is that something you may address in their 20s or 30s? How does that work?
So those are the type of things that I somewhat take care of as well. It's a lot more rare than some of the most current ones, which is AIS. But we do see these patients, and actually, a lot of these patients are actually in a sort of difficult position because the cerebral palsy patients often need intensive multidisciplinary care. They usually have their physiatrists. There's even sometimes the orthosis team that helps them out with everything with the ergonomics. But we do also take care of these patients. The good thing with our current hospitals right now is that some of these cerebral palsy or neuromuscular patients, they do get some continued care with the physiatry team, but oftentimes the problem, and this is what we're trying to work on for the next probably 10 years, Terry, is to connect all the pieces and all these different teams together. As an example, adult hospitals are built to treat adult pathologies, and they're very siloed sort of teams. You've got the cardiac team, and they've worked in just the cardiac conditions. So we're trying to sort of network and build all these teams together that they had when they're in pediatrics into adulthood. For example, we're starting a neurofibromatosis clinic at our adult hospital because we have the neurosurgery teams. But now it's trying to, how do we integrate every single different angle of healthcare professionals that could help these patients in adulthood when they had good care in pediatrics?
Yeah. Again, I commend you. I mean, that's an amazing process that you're developing. So you recently received a grant from the Scoliosis Research Society to study this. Why don't you tell us a little bit about that?
Yeah, so I was fortunate enough to receive some support by the SRS, and it's a early career investigator type of a grant. So the process for that is we submitted a letter of intent. We had an idea, and that passed the first round of reviews, and then we submitted the full grant, which essentially is the first phase of a sort of long-term research program, a long-term vision to provide continuity of care and continued care throughout a lifetime living with spinal pathologies, being scoliosis being one of the first sort of modules. Eventually, we do want to be able to do the same thing with patients who are operated for spondylolisthesis, for example, some of these patients have quite a bit of the reoperations that are needed long term. So the first phase of this study and the central sort of objectives of the grant that we obtained was to have a different angle on research, as surgeons and, Terry, I forget what your background is, but as orthopods, we do love our angle, we do like the values, the calculators, but sometimes we miss, for example, the patient side of things, the patient expertise, the patient experience through all of that. And the main focus of our first research objectives with this grant is to explore the patient's perspectives, the family's perspectives, and to identify their needs so that we could build a dedicated transitional pathway that meets their needs moving forward. Because, as surgeons, we might think, oh, the patient needs a follow-up because we think that post-maturity they'll continue to progress and eventually need some form of surgery. But sometimes the patient's question is a little bit different. They might be asking, hey, what kind of work can I do, or am I going to be able to go to be a professional soccer player? These are actual questions that some of the patients have asked me, and the parents are worried about, whether or not their adolescents understood everything when they were kids, and they worry about their future autonomy. It's very frequent that I even see some 20-year-old young adults with both parents in my office. So truly, we want the patient's perspective at the heart of this first grant to be understood, so that we could use it as information to inform us of how to build a tailored pathway of care for these patients.
Where do you see this ultimately going? What do you ultimately hope to achieve?
So ultimately, I hope to achieve the patient having access to timely care that corresponds to their specific needs throughout a lifetime, being in their 20s, 30s, 40s, 50s, 80s, and that hopefully we're able to build enough long-term follow-up of these patients throughout, and having a patient partner, guide us throughout each phase of life. I hope to have actually a patient that follows the entire process from the 20s all the way to their 70s or 80s, that we could rely on for feedback throughout and continuously improve our process of care, and I think that's sort of our long-term vision that we want to achieve. And hopefully, one of the SRS directed research grants was to look into long-term outcomes. Hopefully, one day we could have this long-term continued follow-up of all these patients and help inform us at the pediatric stage, what's their future going to look like? When do we need to operate them? Should it be at 15? Should it be at 25? Should it be at 35? Do we think that we need to have a surgery at 35 if we plan to be, I don't know, an accountant, or to be something that's a little less lower demand, So if we could tell this 14-year-old from our first visit how things are going to look like with respect to their spine care 40 years in the future, well, I think, we would have advanced in spine care quite a bit. So that's our long-term ambition. Certainly everything starts with the beginning, starts with like some of my mentors have told me, the lower hanging fruits. So we have to start from the beginning if we want to reach to our objectives.
Yeah, and that's obviously, a perfect segue into my next question. So you partially answered it, but we all have our spiel that we give families when they ask, well, if this curve may not get much bigger, or it'll take a long time for it to get bigger, why should my child have surgery at 15 versus 25 versus 35 or 45, just based on, what you've learned so far?
Yeah, that's a very good question. And it's something that, recently the Vanderbilt group has published an article in Spinal Deformity on that, comparing sort of the adult that was 25 versus the adolescent group on some of the results. And essentially, life is a kyphosing event. Life is a stiffening event as well. We see that these patients are a little bit stiffer, surgery is a little bit longer. We maybe need more osteotomies, but at the end of the day, their quality of life is about the same, whether or not you operate them, let's say, in adolescence or early adulthood. So it's a question that I grapple. It's something that's always an ongoing debate internally and as well with the family and the patient, because outside of scoliosis and outside of sort of the clinical care, well, these are young adults and they're going through somewhat a critical phase in their life. I had a patient, she didn't want to get operated. She wanted to travel. She ended up actually going to Australia for 3 years to do her bachelor's degree. She did all that, came back, and scoliosis is pretty stable. She's doing very well, asymptomatic. I feel that from a professional and in a personal aside, that because our values do impact somewhat our clinical judgment as well. We can look at the data, but sometimes listening to the patient and what they are telling you is also very important. I think that if they're doing very well and they have specific objectives that they want to achieve, I think we should listen to that. The patient who is a young adulthood, whether we not operate them at 16, 26, I think we should give them the opportunity to have that decision for themselves and to conclude what they want for themselves in the future. Because a lot of them, when they're 15, 16, even if they're 25, 26, sometimes they come with their parents, but I feel that their parents were a big part of their lives. And maybe at that time, they didn't have necessarily the life experience to handle big life-changing decisions sometimes, So it's a very difficult decision that I have internally. I have 30 to 40-minute consultations with the patients, whether or not they're 16 or 22. They have same patterns of questions of, hey, I'm doing well. I think I want to wait a little bit. I want to have kids before, I want to make my family. So it's a difficult question, absolutely, and I don't know what's the best. I'm not here to say what we should be doing. I think it's the question of the hour. So
yeah, fantastic response. And I'm a pediatric orthopedic surgeon, and I take care of individuals up to around 21, and I think that sometimes we lose sight of what happens after they move on from our care. And, I look forward to hearing from you in the future, and I'm looking out for your results, and hopefully we stay in contact and we can discuss it. You want us to hear about you and what you do and why you love what you do?
Yeah, I think in terms of my current practice, I think it's a big passion. Spine surgery is. I remember the first time Stefan showed me an X-ray of what scoliosis meant, what the surgery meant. I found it just fascinating because it's a challenge all the time, not only the surgeries itself, but also the patient, their needs, their clinical history, everything they're talking about is it comes out very different from what we see in orthopedics. A lot of the times in other orthopedic surgery, some things are very straightforward. Spine surgery is never straightforward. There's always curveballs here and there if you look for them. And I think it's intellectually fascinating, and it's a passion. And also, to be quite honest, one of the other things that maybe go into it was because everyone seemed to be very happy doing spine surgery. Stefan was a great mentor, great role model. I wanted to be just like him, And 14 years later, I'm sort of getting there, but the trail is still very far away. Got a great group of colleagues here at the University of Montreal. on the adult side, very collaborative. We want to be multidisciplinary. We want to build a team model. We are doing a lot of our surgeries as a two-surgeon model, so going to work is a lot of fun, and we talk about spine surgery, all the time, and it's great. I'm happy to go to work every day, so, and I feel very privileged actually to be able to see some of these young adults, come into adulthood, and I think it's fun to be there. They always have things they want to do, their objectives, and you see some teenagers being teenagers. Just today I saw a 16-year-old, and I asked him, what you're doing at 16. He says, I'm playing Assassin's Creed on my PS4. So I was like, okay, well,
Yeah.
his dad laughed a lot when he answered that, but it's a privilege truly to be at this juncture of a lot of these patients' lives. So, well, that's what keeps me going, at least. So hopefully we can make a significant contribution to their care moving forward 5, 10, 15 years down the line.
Yeah, I'm pretty sure you will. Thank you so much for joining me. I've really enjoyed this, and I'm sure our viewers will really enjoy it as well. I'm going to say, a quick good night. Thank you, everybody else, for tuning in, and we will see you in the next episode.
Thanks so much, Terry.
No, you're welcome.